Good morning, everybody. I'm Dr. Agila, Assistant Professor, Department of Pediatrics. And today's topic is a very important topic which we are going to cover. It is nothing but acute CNS infection. Acute CNS infections are the most common cause of mortality and morbidity in young children. It can lead to developmental issues. It can lead to severe morbidity and sometimes death also. So, identifying and management of acute CNS infection is a must-know topic for both undergraduates and postgraduate students. And I hope this presentation will be helpful for you to achieve that goal. Within this introduction, let's go inside the topic. Now, what are we going to know? What is acute CNS infection? What causes it? What happens in the system? How to recognize it? How to prove the presence of an acute CNS infection? How to treat it and how to prevent it? Significance. This, as I told you already, acute CNS infection is a significant morbidity and mortality cause in children. 1.2 million cases worldwide. Diagnosis is actually challenging in young children, and there is high incidence of sequelae, which will lead to developmental issues. Basically, acute CNS infection presents with fever and altered sensorium. So, any child who's presenting with fever and altered sensorium, you will think of a CNS infection. Viral infections are more common than bacteria, and that is more common than fungi and parasite. So, acute CNS infection can be meningitis, meningoencephalitis, or a brain abscess. Common symptoms are photophobia, neck pain or rigidity, stupor, and fits. Diagnosis is mainly by CSF. So now, this is our CSF picture. Now, as you can see, here is your eye, and then there is a CSF pressure. This will go and impinge on your eye, and this is called papillary. Now, these are your ventricles. This is your lateral ventricle, third ventricle, fourth ventricle, spinal cord. There will be a subarachnoid space in the spinal cord, which is an extension of the CSF. Choroid plexus is a production. Arachnoid granulation is absorption. Now we'll go for the first CNS infection, which is pyogenic meningitis. Now, what is the etiology? Now, etiology can be classified into less than 2 months and 2 months to 12 months. Less than 2 months, it is mainly coming from the maternal flora. It could be from the NICU or from the postnatal ward. It could be group B streptococcus, group D streptococcus, gram-negative bacteria, listeria, and H. influenza B. From 2 months to 12 months, it is most commonly bacterial. Pneumococci, meningococci, and H. influenza. H. influenza is now less because of the vaccination which we are giving. Pseudomonas staph aureus and coagulase negative staphylococcus is also important cause of pyogenic meningitis between 2 months to 12 months. What are the reasons for infection? First important reason is less important. Then contact with people with invasive disease. Occult bacteremia, which is present in infants. Immunodeficiency state. It could be a primary immunodeficiency or an acquired immunodeficiency like a HIV infection. Splenic dysfunction. Now, spleen is the main area for sequestration of capsulated organisms. So, capsulated organisms, mainly pneumococci and meningococci, they are capsulated. So, whenever there is a splenic dysfunction, these organisms are more likely to cause infection. Any CSF leak is there, or a meningomyelocele, a pre-existing condition which predisposes the brain to infection, like a meningomyelocele, or you are done a CSF shunt for some procedure, like if there is a malformation or a hydrocephalus for which you have done a CSF shunt operation, this shunt can get infected and this can cause meningitis. So these are all your reasons for infection. Pneumococcal infection, as I already told you, if the child is already having an otitis media, a sinusitis, pneumonia, or a CSF rhinorrhea, now this child is more prone for pneumococcal infection. Meningococcal infection is mainly when a child is having adult contacts of meningococcemia or a nasopharyngeal carriage status. Now, these children are more common for meningococcal infection. H influenza B is mainly from contact in daycare center, but nowadays the incidence of H influenza B has drastically reduced because of our primary vaccination. Pathogenesis. First of all, these organisms, whether it is viral or bacterial, pyogenic is mainly bacterial. So now colonization will happen in the nasopharynx. There will be a prior or a concurrent viral upper respiratory tract infection, and there will be bacteremia. During bacteremia, bacteria is now in the blood. Now this bacteria which is in the blood will go for hematogenic dissemination. Hematogenic dissemination is the main source of infection. Contiguous spread from sinus or otitis media or an orbital or vertebral trauma or from meningocele. This is also an important cause. But hematogenous dissemination following a bacteremia is the most important pathogenesis of pyogenic meningitis rather than contiguous spread. But all children get upper respiratory tract infection. All children are prone for a viral upper respiratory tract infection, but not all of them develop meningitis, right? So what is the reason why only some children develop meningitis and some others don't? Because of defective opsonic phagocytosis. It could be because of developmental defects or absent preformed anticapsular antibodies, deficient complement propagation system, or splenic dysfunction. This is why only a few of them develop meningitis, where most of them don't. Only those who having defective opsonic phagocytosis are more prone for developing meningitis. Now, bacteria will enter through the choroid plexus of the lateral ventricle, circulate to the extracerebral CSF and subarachnoid space. CSF is now almost like a culture medium for the bacteria, where they will rapidly multiply in the CSF. While multiplying, they release a cascade of inflammatory mediators. Tell me, neutrophilic infiltrates. This will cause increased vascular permeability and altered blood-brain barrier. And this also will have high propensity for vascular thrombosis. So this is a very important slide. I told you the bacteria is going through hematogenous route. Now bacteria has entered into the choroid plexus. Now it is going to cerebrate in the extracerebral CSF and subarachnoid space. CSF is now the culture media where the bacteria is rapidly multiplying. Now they are releasing inflammatory mediators. There is neutrophilic infiltration, increased vascular permeability, altered blood-brain barrier, and vascular thrombosis. Because of this pathogenesis, which we discussed here, now there's going to be thick exudates covering all the areas of the brain. There's going to be ventriculitis, arteritis, and thrombosis, vascular occlusion and sinus occlusion, cortical necrosis and cerebral infarct, subarachnoid hemorrhage, hydrocephalus, increased intracranial tension, and inflammation of spinal nerves. Now, these are the result of the inflammatory process which is taking place. This inflammatory process is leading to so much of issues. Basically, your brain is just inflamed. Thick exudates are covering all areas. There is ventriculitis, there is arteritis, there is thrombosis, vascular occlusion is there, sinus occlusion is there. Everywhere there is infarcts and necrosis. Sometimes it's because of the vascular genesis or angiogenesis, there can even be subarachnoid hemorrhages can be happening. These exudates can go and block the CSF flow. This will cause hydrocephalus. This will in turn cause increased intracranial tension and inflammation of the spinal nerves. Clinical features can be non-specific features and meningeal signs. Non-specific features: fever, anorexia, myalgia, arthralgia, and headache. Purpura, petechiae, rash, and photophobia can also be there. Meningeal signs are basically neck rigidity, backache, Wernicke sign, Brzezinski sign, and cross-leg sign. So, non-specific features will start early on. The child will start developing fever, anorexia, myalgia, arthralgia, and headache. The child also will develop purpura, petechiae, rash, photophobia because of the widespread genital involvement. These meningeal signs are very, very characteristic of meningitis. Basically, the neck will become rigid because of the dural inflammation. There will be backache. Wernicke sign, Brzezinski sign, and cross-leg signs are characteristic. But the problem with meningeal signs is that in younger children, they are very, very difficult to demonstrate. It can be typically seen in older children. Now, this is nuchal rigidity. This is Brzezinski sign. This is spine sign, tripod sign, Lasagne sign, and Wernicke sign. Now, this is how you demonstrate the Wernicke sign. When you just extend the leg and try to extend the knee, there will be pain in the neck. What are the signs of increased intracranial tension? Headache, vomiting, fits, ptosis, squint. Smaller children can have anterior fontanelle, which is bulging, widened sutures, hypertension, bradycardia, stupor, coma, abnormal posturing, papilledema, which is only seen in chronic ICT. So this is ICT sign. ICT is nothing but intracranial hypertension or intracranial increased intracranial tension. It can be either clinical signs like symptoms or signs which are demonstrated. I'll go through it again for your information. Headache, vomiting, fits, ptosis and squint, anterior fontanelle bulging and widened sutures, hypertension, bradycardia, stupor, coma, abnormal posturing, and papilledema. Focal neurological deficit can be there. Cranial neuropathy, especially of the third nerve, sixth nerve, seventh nerve, and eighth nerve can be there. Diagnosis. Diagnosis is mainly by doing a lumbar puncture and CSF analysis. Lumbar puncture procedure, usually it is done in the L2, L3 space. In smaller children, it is even higher up. In a very sterile way, you are going to prepare the area, taking a lumbar puncture needle, inserting into the space, into the subarachnoid space, and then you can see the free flow of CSF. Opening pressure can be monitored, and then you take the sample separately for microbiology, pathology, and biochemistry. Microbiology sample will be sent for gram stain and culture, where you can directly see the organism in gram stain, or culture the CSF and see what kind of growth is being present. And then you send one sample for pathology, where you see the cell count. You see how many neutrophils or lymphocytes are there. And one sample is sent for biochemistry, where you do glucose and proteins. One of the main contraindications for lumbar puncture is increased intracranial tension. So when you have signs of raised ICT, you are not supposed to do lumbar puncture because it will cause coning of the brain. Apart from this, you're going to also do blood culture. Now, this is a procedure how I explained. The patient is put in left lateral position. Under sterile precautions, you're entering the spinal needle is entering into the subarachnoid space where there is CSF. Now, CSF is drawn for sample. Now, what is a CSF analysis? Now, we are going to look at the cell count. Normal cell count Newborns will have more than 30 per cubic millimeter, but children will have almost 5 or 5 to 10 maximum, not more than that. In meningitis, it is even more than 1000 cells per millimeter cube. Turbid, it could be turbid 200 to 400 per millimeter cube. Early lymphocytic predominance will be there. Later, there will be neutrophilic predominance. Low and severe sepsis. So this is a cell count. Normal count is only so much. In meningitis, the cell count is increased to more than 1000 per millimeter cube. Now this is a cells. Now can you see these lobulated nuclei? This is your neutrophils. This is your lymphocytes. So this is a increased cell count. When you see it in the microscope, this is how it will look. So this is actually neutrophil predominant. You can see 1, 2, 3, 4, 5, 6. Only in this field itself, you can see so many neutrophils. This is gram stain. You can see gram negative rods. CSF analysis is done prior to antibiotic therapy. Culture and gram stain can alter the things. Pleocytosis, protein and glucose are unaltered. What is traumatic LP? While doing LP, in case you traumatize some blood vessels, blood can leak into the CSF, because of which the cell count and protein level can be altered, but glucose and bacteriology is unaltered. So even a traumatic LP can give you a result, which is going to help with your treatment. Now this is a most important slide. So just based on lumbar puncture and CSF analysis, you are going to differentiate between the etiology of acute CNS infection or acute meningitis. Before knowing everything, we should know the normal. What is the normal pressure of CSF? It's 50 to 80 millimeters of water. Cell count is usually less than 5 and it is lymphocyte predominant. Glucose is more than 50, which is almost 75% of the blood glucose level. Protein is only 20 to 40 milligram and there will be sterile. There will not be any microscopic features or any microorganisms found in the CSF. So pressure is 50 to 80. Cell count is less than 5, which is lymphocyte. Glucose is more than 50, which is 75% of the blood glucose level. Protein is 20 to 40 milligram per deciliter. Now what happens in bacterial meningitis? Bacterial meningitis, the pressure is 100 to 300 millimeters of water. Cell count is between 100 to 1000, out of which more than 75% is neutrophils. Glucose is very less, this less than 40. Protein is elevated, it is between 100 to 500 milligram as contrast to normal 20 to 40. And gram stain will be positive for the bacteria. So it is very important to know the features of bacterial meningitis in the CSF. Now what happens in a partially treated meningitis? The pressure can be normal or elevated. Cell count can vary between 5 to 1000 and it is mostly lymphocyte predominant now. Glucose is normal or decreased. Protein is between 100 to 500. Gram stain may be negative, but antigens will be positive. Because it is already present, antigens will come positive. What are the features of viral meningitis? Pressure is normal in viral meningitis. Cell count is usually less than that of bacterial and it is mostly lymphocyte predominant. Glucose is normal, but it can be less in mumps meningitis. Protein is also elevated, but it is not that elevated like bacterial. It is less than 200. And gram stain will generally be negative. Tuberculous meningitis, pressure is more. Cell count is also around 500, but it is lymphocyte predominant. Glucose is less. less than 40, protein will be very, very high. It is characteristic of, sorry, protein level being very high is characteristic of tubercular meningitis. Gram stain will be negative, but culture will be, might be positive. Fungal pressure is more. Cell count will be between 5 to 500. Glucose will be normal. Protein may be more, and microscopy, it is gram stain is negative, but culture, viral culture can yield the specific virus which is causing the meningitis. So this is a most important slide, take home slide for your lecture. How will you differentiate? This can come as a separate short note for you guys as well. How will you differentiate different etiologies of meningitis depending upon the CSF picture? Now coming to the treatment. So rapidly progressive meningitis, just within 24 hours, you do a LP, you give antibiotics, you look for focal neurological deficit is there, then you do CT brain. If there is increased intracranial tension, you treat the ICT, manage the shock and the ARDS. Subacute course, like in 4 to 7 days, you assess for increased intracranial tension and focal neurological deficit, start antibiotics, do CT and LP. Now, what is supportive care? Apart from giving antibiotics or antivirals, which are given for viral meningitis, supporting care is present. You're giving. First, you're doing monitoring of the vitals, monitoring the blood urea nitrogen, electrolytes, bicarbonate, your CBC, platelet and calcium, periodic neurological assessment. You're going to assess the sensorium, the power, the cranial nerves, and the head circumference. Supportive care in view of IV fluids. Usually you have to restrict IV fluids for intracranial tension and SIADH. You give more IV fluid for shock. Management of intracranial tension, it is mainly by ETI and ventilation, furosemide mannitol, and management of seizures with diazepam and phenytoin. Antibiotic therapy, it depends on the organism. If you're suspecting a pneumococcal, meningococcal or H influenza B, antibiotic of choice is a third generation cephalosporin like cefotaxime or ceftriaxone and adding a vancomycin cover. If your suspicious organism is Listeria, antibiotic of choice is ampicillin mainly, IV ampicillin. And in immunocompromised patients, you should go for anti-pseudomonal antibiotic like ceftazidime and aminoglycoside. Antibiotic therapy also depends on gram stain and culture values of the CSF and the blood culture as well. Duration of therapy, for pneumococcal disease, it is 7 to 10 days. For meningococcal disease, it is 5 to 7 days. H influenza B, it is 7 to 10 days. E. coli and Pseudomonas, you have to give for 3 weeks. So it is a very, very long duration of therapy for E. coli, Pseudomonas, gram-negative organisms. Antibiotics can start at before LP, partially treated meningitis. Ceftriaxone is given usually for 7 to 10 days. This is regarding the duration of therapy. When will you repeat your lumbar puncture? You will usually repeat after 48 hours, especially for resistant pneumococcal meningitis or a gram-negative meningitis, where if you're not finding any improvement following antibiotic therapy, you can do a repeat lumbar puncture after 48 hours. It is not routinely done, but it can be done for resistant pneumococcal disease and gram-negative meningitis. What is the role of corticosteroids? It is going to, we also give, apart from antimicrobial therapy, we will give corticosteroids in meningitis. It will cause rapid bacterial killing, cell lysis, release of inflammatory mediators, edema and neutrophilic infiltration, everything will come down. It is usually given 1 to 2 hours before antibiotics. Dexamethasone is a drug of choice, which are giving Q6 hourly for 2 days. It has been associated with less fever and less evidence of deafness following meningitis. What are the complications of meningitis? We've already discussed raised ICT and herniation. Fits can happen, seizures. cranial nerve palsy, dural venous sinus thrombosis, subdural effusion, syndrome of inappropriate ADH secretion, pericarditis, arthritis, anemia, and disseminated intravascular coagulation. So many complications can be associated with meningitis. Prognosis: mortality is more than 10%. More mortality is seen in pneumococcal disease. Prognosis is poor in infants if there is evidence of seizures for more than 4 days, if there is coma or a focal neurological deficit which is present on presentation. Neurological sequelae is seen in 20% patients. Behavioral changes is seen in 50%. Deafness is associated with pneumococcal meningitis and H influenza B meningitis. Visual loss can be present in some patients. Mental retardation can be seen and fits can be seen. Prevention. Meningococcal disease. If there is meningococcal disease in the family, rifampicin can be given to close contacts. 10 mg per kg per day, BD for 2 days. Quadrivalent meningococcal vaccine is also present for, it can be given for high-risk children. H influenza B, rifampicin is again given for contacts for 4 days and a conjugate vaccine is available. Pneumococcal also, heptavalent conjugate vaccine is available. Now TBM. Subacute or chronic meningitis is a feature of TBM. It is mainly from lymphohematogenous dissemination. Caseous lesion is present in the cortex or the meninges. Discharge of TB bacilli is seen in the CSF. Thick exudate infiltrate the blood vessels. Inflammation, obstruction, and infarct can be seen. The typical feature of TBM is that brainstem is affected. There will be cranial nerve dysfunction. Because of the exudates, there will be hydrocephalus, infarcts. Cerebral edema can be there. SI-ADH can be there, and dyselectrolytemia can be there. Features: it is usually seen between 6 months to 4 years, and TBM has got 3 stages: prodromal stage, abrupt stage, and a coma stage. Prodromal stage is between 1 to 2 weeks with a non-specific symptom and stagnant development. Abrupt stage has lethargy, fits, meningeal signs, focal neurological deficits, cranial neuropathy, hydrocephalus, and an encephalitic picture. Coma stage has posturing, hemi or paraplegia, and poor vital signs. Diagnosis: contact with adult TB will be there. History of contact with adult TB. MANTO can be non-reactive in as many as 50% patients. CSF is having lymphocytes. Glucose is less than 40. Protein is very, very high. We have already discussed in the CSF picture. Protein is exorbitantly high, and acid-fast bacillus can be present in 30% patients. We've completed meningitis. Now we'll go to meningoencephalitis. It's acute inflammation of the meninges and brain tissue. CSF will have pleocytosis. Gram stain and culture is mostly negative, and it is mostly self-limiting condition. Etiology of meningoencephalitis is enterovirus, arbovirus, and herpes virus. Pathogenesis is by direct invasion and destruction by the virus, host reaction to viral antigens, meningeal congestion, mononuclear infiltration, neuronal disruption, neuronophagia, and demyelination. So basically this virus is entering and causing host reaction because to the viral antigens, and this is causing a array of problems, mainly because of a inflammatory response. This is very important. HSV meningoencephalitis is mainly affecting the temporal lobe of the brain. Arbovirus is affecting the entire brain, and rabies is affecting the basal brain. HSV is temporal brain, arbovirus is entire brain, and rabies is basal brain. Clinical features depends on parenchymal involvement, preceding mild febrile illness and exanthem. Acute onset of high fever, headache, irritability, lethargy, nausea, and myalgia can be there. Convulsion, stupor, or coma will be there. Fluctuating focal neurological deficit, emotional outburst also can be there. Anterior horn cell injury can cause flaccid paralysis, especially it is seen in West Nile virus and enterovirus. So these are the clinical features. Differential diagnosis is meningitis of various organisms. Diagnosis is mainly done by CSF, which is lymphocyte predominant. Protein can be normal but high in HSV. Glucose is again normal but low in mumps. Culture of organism can be seen in enterovirus. Viral antigen by PCR can be sent. And culture from nasopharyngeal swabs, feces or urine also can be sent. EEG can have focal seizures, especially in the temporal area and HSV. CT or MRI usually will show brain edema, which is swollen brain parenchyma. Treatment, acyclovir is a treatment of choice for HSV, non-aspirin analgesics, and you're nursing the baby or the child in a quiet room. Now the last of the acute CNS infection is brain abscess. What are the predisposing conditions to brain abscess? First is the cyanotic congenital heart disease, meningitis, penetrating head injury, local extension from mastoid, otitis, sinusitis, or soft tissues of the facial scalp. Etiology of abscess is mainly Staphylococcus aureus. Other organisms is microaerophilic streptococcus, other aerobic and anaerobic organisms. Mixed infections can be seen in 35% of the patients. Clinical features involve fever, headache, vomiting, focal neurological signs, and increased ICT. Blood counts are non-specific. CSF can be normal with slight pleocytosis. EEG can show focal slowing. What is the diagnostic method of choice? It is CT scan. CT scan will show your specific abscess in the brain. Treatment is IV antibiotics, cover for anaerobes, and surgical drainage of the brain abscess. So we've completed acute CNS infection. I'm going to revise one of the very important slide, which is this one. CSF picture and the etiology. And the most important take-home message is that bacterial infection is mainly neutrophil predominant with very high cell count, less of glucose and more proteins. And TBM is going to have lymphocyte predominant with exorbitantly high proteins and low sugar. So this is a very, very important slide. If any of you are having any doubt, you can always contact me to just go through the questions which we discussed earlier. We saw what is it? Acute CNS infection is mainly acute bacterial meningitis, acute viral meningitis, fungal meningitis, TB meningitis, meningoencephalitis, which is mainly viral, and then brain abscess. What happens, how to recognize it, and about CSF analysis. Treatment we saw in detail, and prevention we have seen all the vaccines which are available for different bacterial organisms. So I hope all of you understood acute CNS infection. You can please contact me if you have any doubt. And we can end our class here. Thank you so much. Thank you.